So thanks for those who have joined for the session today. So this is a overview of the brain tumors. As you know, brain tumors is a big topic. It's difficult to do justice in our for all the tumors, but the overall theme today will be kind of overall picture of how common they are, what different types are there, in general, how do you normally approach the brain tumors, and that kind of a thing. So you can either put your hands up if you have questions through my presentation or text along the way. And I think Boo Boo is going to keep an eye on who is popping the hands out because I can't really see the screen that much here. So um, let's start. Okay.
Great.
So it's always difficult, when you see children playing, laughing, and being together and all that. Is there a child among these? One of them may have a brain tumor. It's not still made its clinical appearance yet, or it's in the early stage that there are no symptoms and warnings. So it's a difficult thing for brain tumor because often it's hidden. Symptoms are hidden for a long time. So if you look at just the top half of the screen, for example, in this case, a 6-year-old female child complains of headache and vomiting, right? If you assume that there is no unsteadiness of gait and difficulty in walking at this point of time, we often think that, it's so common. Headache and vomitings are quite common, can happen with viral infections and other things. So we tend not to worry too much, but most of the time it is a common symptom, common ailment, and resolves, and the child will get back to normal and all that. But uh, among them, rarely some children go and develop other symptoms or signs that indicate tumor. So when unsteadiness of the gait develops, visual deterioration develops, and you get signs that I mentioned there, cranial nerve palsies or sensory motor deficit, and when you examine they have papilledema, gait abnormalities, then it's more obvious that the brain tumor, this child has got a brain tumor. Similarly, the other two case scenarios here, 7-year-old male complaining of difficulty swallowing, speech weakness, double vision, altered sensorium. Nobody needs to tell you that there's something going on in the child here. And the third one, a 14-year-old child complains of headache, then develops memory loss, develops seizure. So people will certainly go for these children to be investigated further. But what happens to those who do not present with full-blown symptoms? That is when I think most of you would have probably heard of Head Smart campaign. Head Smart campaign was a national campaign, went for many years initially symptom collecting, then putting them together, analyzing, and putting together a program for making people aware of brain tumor and how to recognize in children and babies, especially targeting schools, nurseries, and various allied health professionals and general public. So just to be aware of, there is a, if you go on the Google and look for Head Smart symptom card and Head Smart campaign, you'll get a website which is dedicated to this early recognition of brain tumors. So I won't spend too much time on that. I just wanted to make you aware of that. So amongst that, in the website, if you go for the health professionals, there is a very, very concise but still detailed card, or which tells you what are the symptoms and when to suspect brain tumors, and when to refer and when to do investigation, that kind of thing. And HeadSmart campaign website also has got an interactive learning, module which you can go and do yourself and learn more about brain tumors, how to recognize and how to refer early. So this is another poster from them showing that the children with brain tumor don't often go to neurosurgeons or oncologists. They often go to varied specialties like psychiatry, ophthalmology, ENT, gastroenterology, respiratory, endocrine, maybe in community, neurology, So it's very, very varied presentation. So because the symptoms are so many different things that can happen, so it's difficult to recognize by one specialty. So everybody needs to be aware of brain tumor symptoms and how to recognize them in children. So coming back to what we know so far about brain tumors in children, brain tumor accounts for about 20%. Now it's actually more like 25% of children under the age of 15 years. It's the most common solid tumor as a group in children under 15 years. It's only second to ALL. Acute lymphoblastic leukemia is the most common, and almost equal or slightly less common is the brain tumor as a group. The problem with brain tumors are, even though it's the second common one, it accounts for high morbidity and mortality, especially because of the late diagnosis by which neurological damage has already happened, and the treatment associated with brain tumors do come with a lot of cost. So in terms of population demographics, you can say 3 per million population. So although we say 3 per million population in the UK, actually we see slightly more than that. You're looking at about 400 to 500 cases per year in the UK. There's not really much difference between male and female distribution, so 1.2 to 1.1. And what was recognized was between 1973 to 1994, and even now it continues to rise. The incidence of tumors in brain in children and adolescents are increasing still. So what are they? Actually, if you look at what kinds of brain tumors children get, astrocytomas, astrocytic tumors, they are the most common. So then medulloblastomas are previously called primitive neuroectodermal tumors. They are the next common, 20% and 60%. So together they make up about 80% of them. And about 8% craniopharyngiomas and 10% ependymoma. All the other tumors are 2%. So when we talk of brain tumors, often in the wards in clinics, you see either an astrocytoma or an ependymoma or a medulloblastoma. Those are the more commons. Craniopharyngiomas are mainly managed by the neurosurgeons and the endocrines, so you don't see them on the wards, on the oncology wards much. So this is from the SEER program, the US data, statistics, epidemiology, and end result program. I've got an up-to-date slide in the next one. So just to show the trend of different types of cancers in children. So for example, I don't know whether you can see my, so the blue one is the brain tumor. So it's highest in the first 7 to 8 years of life, incidence wise, and then it declines gradually. By the age of 19-20, it's the lowest. Then it starts to rise again. So, and the second peak is there at 40 to 50 years of age, the second peak happens. And you can see the acute lymphoblastic leukemia on the other hand, ALL, its peak is 3 to 4 years of age, and then it falls rapidly. It's kind of similar to brain tumor, but it's higher in the first few years. Whereas the AML, acute myeloid leukemia, continues to drop in the first 4 years, but then reaches a steady state. And it actually again reaches a higher peak in the adulthood again. Sorry, going back. So the lymphoma, on the other hand, is lowest in the early age, but then by adolescence, 10 to 20 years of age, the increases more. So this is what is happening from 2000 to 2016. Incidence of brain tumors. The top one is the incidence, 3 per. It used to be around 3 per million. It's now more or equal to 3.5 or 3.6 per million, and the blue is the death. So there's still quite a bit of children are dying. It's not in terms of percentage, but in population, the death is still happening quite a bit in children with brain tumors. The death is not all the cases diagnosed. In terms, that's more like a prevalence. That's why it's still 3 rather than incidence. Incidence is 3, but children who having existent brain tumor also die. That's why it's sort of similar. So when they're diagnosed, most of them are localized. The blue is the localized one. So the tumor is localized to one region in the brain when they're diagnosed, most of them. So regional spread, that means beyond the site of origin to another part of the brain is green. And then distant metastasis to the spinal cords, meninges, and other things is the purple one. And the one in the brown is unstaged. So staging information is not known for them. But what's good about brain tumor is the survival rate has dramatically improved over the years. So, it used to be around 10% to 20% 25 years ago, and then gradually now it's 74.9%, and it continues to be increasing recently. So, which is really good actually, considering how malignant some of these tumors are. So in terms of when we talk about brain tumors, we talked about, you might have heard us saying supratentorial tumor and an infratentorial tumor. So if you look at the head, the tentorium cerebelli, which is the ligament, just divides the head into upper portion and the lower portion. So there you have the cerebral hemispheres, the ventricles, and the falx cerebri and all that. And infratentorial is where you have the cerebellum, the brainstem, the spinal cord starts, and the fourth ventricle and all that. So as you can see, in order to understand where the tumor develops in these locations, supratentorial compartment, which is the upper compartment, has cerebral hemispheres, which is the peripheral ones, then the basal ganglia, which is the kind of more medial one, and then the middle one, the thalamic one, the lateral ventricles, hypothalamus, and corpus callosum. So it shows in the picture here. So this is the cerebellum, tentorium cerebellum, which is below this is the infratentorial portion, which causes the brainstem, the cerebellum, the fourth ventricle, and the start of the spinal cord. Whereas this one has the cerebral hemispheres, the corpus callosum, thalamus, and all that. So in terms of location, fairly sort of similar. So in children, infratentorial tumors are slightly more, 45 to 60%, whereas supratentorials is between 35 to 45%. In that, most of them happen in the hemisphere, cerebral hemispheres, 25 to 40% of them. Whereas the midline ones and the suprasellar region and the pineal regions, they are 15 to 20%. So in the infratentorial tumors, what are the common ones? That is the posterior fossa. We call that most of the times posterior fossa, infratentorial region. Medulloblastoma is the most common one, 20 to 25%. Then the astrocytic tumor is about 12 to 18%. Then ependymoma. Those are the 3 common ones in the posterior fossa. Malignant tumors can happen mainly in the brainstem, which we call as DIPG, diffuse intrinsic pontine glioma, about 3 to 6%. So in terms of distribution, supratentorial ones, astrocytic tumors are more common here, whereas the medulloblastomas were more common in the infratentorial one, 8 to 20%. Low-grade ones. The malignant gliomas, 6 to 12%. So as a group, astrocytic tumors are the most common in the supratentorial compartment. Then the ependymoma. You can see that the medulloblastoma doesn't happen in the supratentorial compartment. Similar tumor known as primitive neuroectodermal tumor can happen, which is similar to the medulloblastoma, 1 to 2% in the supratentorial compartment. But there are other different types of tumors which are rare. In terms of midline tumors, so we talked about the hemispheric tumors. In terms of the midline tumors, sorry, you can see midline tumors are the most common one, about 9%. So they are mainly treated by surgery and radiotherapy, so we don't see them on the oncology wards that much, but they are benign tumors, but they are common in the midline. But you can also get astrocytic tumors, hypothalamic chiasmatic tumors. So we often talk about optic pathway glioma, optic pathway chiasmatic tumors and all that. Those are astrocytic tumors. And then there are others, germ cell tumors and others. This is a busy slide and it's difficult to read, but just a summary to say astrocytomas are the most common, 35%. Then medulloblastomas are 20%, ependymiomas are 8%, brainstem glioma, and then craniopharyngioma. They are the next ones. So how do they present? How do they present, and what can we do to find out how they got brain tumors? So pretty much you can see it depends on the age of the child and where the child's tumor is located, where it is starting. The children can have either a non-localized symptom, often due to mass effect, tumor mass, or due to a blockage of a CNS pathway, CSF pathway, like causing raised intracranial pressure, hydrocephalus, things like that. So when you're talking about non-localized symptoms, you're talking about weight loss, listlessness, irritability, very non-specific symptoms like decreased appetite, lethargy, withdrawal behavior, headache, vomiting, double vision sometimes. So as you can imagine, especially in the infants, when they are young, viral infections, bacterial infections, in lots of other things, gastroenteritis, UTI, so many things cause many of these symptoms. But the crunch line is you expect the viral infections, viral gastroenteritis and other symptoms to last for maybe a week or maybe maximum 2 weeks, and you expect the child to get better. If they are persistent, so persistent symptoms need to be investigated. They may not have brain tumor, they may have another underlying cause, but they need to be investigated for that. So if you have a localized, so symptoms caused by localized factors, where depending upon where they are, what symptoms they can cause. So infratentorial tumors, for example, the posterior fossa is very tight. It's a small compartment. There's already cerebellum, brainstem, the fourth ventricle. There's not really any space there. So any tumor starting there will raise the intracranial pressure very much. So often the present children will develop headache, vomiting, then because of the long tracts going to the legs, they develop ataxia, gait symptoms. And sometimes they develop non-specific eye symptoms like diplopia or squinting, like that. If they have supratentorial tumors in the cerebral hemispheres, they cause motor symptoms like weakness of limbs, loss of sensation. If they're in the visual areas, abnormal visions. If they're in the temporal lobe, memory problems and learning difficulty and all that. So if it's an intrinsic brain tumor, they can cause diplopia, swallowing difficulty, breathing difficulty, or weakness of limbs, raised ICT. When I'm talking about intrinsic brain tumors, this is mainly the brainstem tumors that I'm talking about, because brainstem has got the cranial nerves nuclei in there. The lower cranial nerves, which help in movement of eye, swallowing, breathing, and all that. And the other ones, specific ones, are the deep midline tumors, which often goes to the endocrine department or the vision, the ophthalmologist, because of hypothalamic pituitary disturbance or visual pathway interruptions, growth abnormalities, short growth, and all that. So those are the symptoms. Then when you're examining the children, you're looking for symptoms and also signs. So non-localized signs are when you examine a child with a headache and a vomiting, if you have papilledema, or if the child's head circumference is increasing, or the squinting of the eyes is there, and then cranial nerve palsy, especially the sixth nerve, abducens nerve. So that means there is something happening inside the brain there. And again, depending upon where they are, localized symptoms, if they're infratentorial tumors, it's mainly balance, defect in coordination because cerebellum is involved, nystagmus, abnormal speech. And then if there is intrinsic brain tumors, like the brainstem ones, as I said, so they are mainly cranial nerve symptoms or long tracts like weaknesses, ataxia and things like that. If they are supratentorial tumors, you are looking at either sensory, motor, visual field, cognitive difficulties and things like that. If they are deep midline tumors, as we talked about, endocrinopathies, visual acuity, visual field abnormalities. Another one is particularly called Perinaud syndrome. I don't know how many of you are actually familiar with Perinaud syndrome. It's very typical. It's rare, but if it happens, it's a syndrome. It's a sign of something going wrong in the brainstem. It may be tumor, it may be hemorrhage, maybe anything, but something going on. If basically it's the upward gaze palsy, and the eyes are convergent, the pupillary reflex is sluggish, but accommodation reflex is still preserved, and there may be visual field abnormality. So that's a combination called Perinaud syndrome. If you see that, then there's definitely something wrong with the brainstem. So when they come, they often get these investigations, not in any particular order. Most often, they get a CT scan in a district general hospital, or if they come to our children's hospital, also they get CT scan first. Easy to do, doesn't require GA. If they're very young children, very babies, newborn babies, very young ones, they get an ultrasound scan looking at what's happening. Then the definitive investigations will happen, the MRI, MR spectroscopy, MR angiography or venography, and then they get lumbar puncture, CSF. And they also get blood markers like alpha fetylprotein, beta HCG, and other hormones like prolactin or growth hormone or whatever. And then when they come to the oncology, I think then they will have more investigations, maybe like functional imaging or thallium, gallium, etc. So when the investigations are done and you look at them, CT scan is very quick, as I said, less than 5 minutes. It can detect space occupying lesion and also alteration in the ventricular size. For example, in this one, these ventricles are enlarged, right? Lateral ventricles. There's a third ventricle is also enlarged. The tumor is actually going into the third ventricle here. And there may be some hemorrhage here in the ventricles that you can see. So it's very quick and provides useful information with regards to what's happening inside the brain. When you do an MRI, you are more specific. For example, this is the posterior fossa, which is below the tentorium cerebelli. So you can see that there is cerebellar hemispheres on both sides and there is a tumor in the middle. This is a typical location of a medulloblastoma. So you can see here, that's a sagittal view. This is the axial view. So you can see that the ventricle is enlarged here because it's obstructed here, and there's a tumor here. So this is what we were talking about, the intrinsic tumors, which is brain. It's swollen like a bulb. So it's very diffuse and the signal is very uniform, and the cerebellum is not much affected at all, and there's nothing else is happening. And this is very typical of an intrinsic brain tumor within the brainstem, which we call as a brainstem glioma. So pediatric are the brain tumors. In other words, some of them are supratentorial ones like astrocytomas and ependymomas. The astrocytomas typical location in the cerebral hemispheres is they have mixed solid component, cystic component. This one is in the ventricle. Within the ventricle, it's an ependymoma, which has got solid component as well as cystic component with enhancement around it. And this is a midline one, which we talked about. A midline one, remember we talked about the endocrine, visual, growth hormone deficiency, obesity and all that. That's the typical location of a pineoblastoma, just in the pineal gland region. So you can see it's in the midline. And this is the craniopharyngioma. So as you can see, it's just above the floor of the mouth. So often the origin is from the Rathke's pouch, which is an embryological remnant that is left in the brain. And so that is a typical location where the hypothalamus and the pituitary glands are located just in front of the pineal gland and the brainstem. So often when we talk about broad principles of treatment for brain tumors, it's generally goes like that. Surgery is often the first step, because surgery is often gives you the diagnosis. Radiologically, you can make out there is a tumor. So craniopharyngioma you can recognize because there is calcification, mixed origin and all that, typical location. Most of the other tumors is difficult to be sure. DIPG is the other one you can recognize. You don't need tissue diagnosis. Whereas surgery, if you do a biopsy, you can diagnose. You can debulk. That means you can reduce the tumor burden. You can do complete excision sometimes. It's not always possible to do complete excision, but subtotal or complete excision is possible in some areas. Only sometimes debulking is possible, or only a biopsy is possible sometimes. And the biopsy can be open biopsy, or it can be a CT guided or a MRI guided biopsy, stereotactic biopsy they call. So often they use neuronavigation. That means using intraoperative MRI to operate extensive microsurgical dissection, taking hours and hours to do complete resection. So, but before you do the surgery, preoperative or perioperative management is very important. Often these children come up with raised intracranial pressure, sometimes endocrinopathies, sometimes seizure, and sometimes hydrocephalus. So if they have got a localized tumor, and there's usually edema around the tumor, which causes pressure symptoms. So often seen in the large tumors, but small tumors in critical areas. Often they are started on steroids, dexamethasone, 6-hourly or even 8-hourly, 24 hours before the surgery is done to reduce the pressure. And after the operation, you can start tapering the steroids. Sometimes they are very unwell when they present with obstructive hydrocephalus, severely raised intracranial tension. They end up in ITU through the A&E, and they often get CT scan under GA, and they get shifted to ITU or to theater directly. Neurosurgeons get involved, and they have to do a urgent intra and periventricular tumors are the ones that cause it, and they have to do an extraventricular drainage, EVD or ETV, endoscopic third ventriculostomy. This is an internal procedure. That means they put an endoscope and they open up the third ventricles and divert the CSF from third ventricle to the undersurface of the brain. So it's not a normal practice to go and do the VP shunt in the beginning. They do the EVD, which is shunting it out. So because the risk of blocking and infections is quite higher if you do it at the onset. After the surgical procedures, you can either close them permanently or make it a permanent VP shunt if the child needs it. Children can present with seizures, typically the cerebral hemisphere tumors. You may have to start anticonvulsants. Phenytoin is for urgent control, but then most often they are on Keppra because that doesn't interfere with chemotherapy and other drugs, and it's very effective and well tolerated. Most often they can be stopped after the surgery and the treatment because they don't need it for lifelong. Then the other problem is the hypothalamic pituitary hormone deficiency. They may be diabetes insipidus, cortisol deficiency. Those are the two main ones. They can have thyroxine as well. These are the tumors that are close to the hypothalamus or the pituitary axis. So endocrine need to get involved, fluid electrolyte balance needs to be kept, and hormone replacement needs to be done. So it requires about 24 to 48 hours or sometimes up to 72 hours to prepare them for surgery while doing all this. So once the surgery is done and we know what the tumor is, treatment is either radiotherapy or chemotherapy. In general, most of the tumors are treated with radiotherapy if possible, because radiotherapy has got a better track record than chemotherapy. Although now the change is more towards more chemotherapy or novel therapies to avoid toxicity from the radiotherapy in the long run. So in terms of radiotherapy, they use high energy machines like photons. They used to electrons before, but now mostly photons. Now the recent ones is proton, because proton can minimize the radiotherapy to the normal brain around it, and it can focus better into the area where you want to deliver radiotherapy. So the protons are, there is one proton center in Manchester at the moment. You often see our children going to Manchester. Previously, they used to go abroad, either to USA or to Germany, because that's where we were sending children. It can be either localized radiotherapy or it could be to the whole craniospinal axis, the whole brain and the spine. It can be usually around 50 to 60 gray for the whole brain. For the spine, it's only 24 to 36. It's done in fractions, small fraction each day, 5 days a week for a couple of weeks, several weeks, 5 to 6 weeks time. And there are some tumors which are very small, which can be treated by stereotactic radiosurgery or stereotactic radiotherapy, interstitial brachytherapy, which can be conformal. Or there is another technique called VMAT, or the intensity modulated treatment, which is available in Beatson as well now. And for STRS, we used to send them to Sheffield for doing the stereotactic surgery. In general, radiotherapy should be avoided for children under the age of 3 years because of developmental concerns to the brain and damaging effects. So what about chemotherapy? Chemotherapy is standard and useful for medulloblastoma, malignant astrocytoma, that is high-grade gliomas and high-grade astrocytomas, astrocytic tumors, aptic pathway gliomas, germ cell tumors, and all children with a malignant tumor under the age of 3, because they can't have radiotherapy, we use chemotherapy for them. They can have upfront chemotherapy, or they can have neoadjuvant chemotherapy, that means after the surgery, or they can have high-dose chemotherapy with stem cell transplant, which medulloblastomas are the main ones that we use to treat like that. And there are lots of different drugs which we all see on the ward, like lomustine, vincristine, steroids, procarbazine, carboplatin, cisplatin, methotrexate, vincristine, temozolomide, and various other drugs. Just a few things about medulloblastoma, because that's one of the common ones that you see on the ward. They can be high risk or standard risk. So generally, children who have metastasis into the CSF, which is when you do the CSF and you find cells in there, or when you do MRI and you find spine is involved, they are high risk. If there is a residual tumor after the operation more than 1.5, if children are under 3 years of age, then they are treated with both radiotherapy and chemotherapy. Although wait until they are over 3 years for doing the radiotherapy. Standard risk children are treated with radiotherapy and chemotherapy. See, all the others fall into the standard risk. And then you do radiotherapy first and then do standard chemotherapy after that. Astrocytomas, if they are surgically resected, you don't really need to do any more treatment. If they're completely resected, you can just follow them up with scans. So, but if they are recurrent, If still possible to do surgery, you can do it. But if surgery is causing morbidity, then adjuvant treatment will be usually radiotherapy if they are older children. That means if they are more than 8 years of age, or chemotherapy if they are under the age of 8 years. Ependymiomas, they are usually in the posterior fossa, but they can be in the supratentorial compartment as well. Surgery is the mainstay of treatment. Chemotherapy is really not that effective, but we use chemotherapy for children under the 18 months of age. We used to use under 3 years of age, but with the proton now, you can certainly do even for those over 18 months, you can do radiotherapy with minimizing the effect on the normal brain. So now we are doing it under the 18 months of age, primary chemotherapy for ependymiomas. Diffuse intrinsic tumors in the brainstem, radiotherapy is the only one that is effective for short-term control, unfortunately not for long-term control or cure. Various chemotherapies have been tried, but they are not useful. And these are not eligible for surgery because they are intrinsic tumors, so they can't be resected. So hemispheric specific tumors, the supratentorial tumors, when they are happening in the cerebellar hemispheres or in the midline. So for low-grade gliomas, surgery alone, plus or minus adjuvant chemotherapy if they are recurrent or if it is incomplete resection. If they are high-grade, surgery is the mainstay, followed by radiotherapy, and temozolomide chemotherapy can be considered. Ependymiomas, surgery is the main treatment, radiotherapy is the adjuvant treatment to consolidate. And then there are midline tumors like optic pathway gliomas, hypothalamic gliomas. Surgery is almost impossible in this region because it will cause damage. So biopsy is the main thing that they do. And so increasingly we are using chemotherapy, decreasingly using radiotherapy because radiotherapy also damages the optic pathways, the hypothalamus, leading to visual impairment or endocrine impairment. So chemotherapy is often used for these patients. Craniopharyngioma, surgery is the main treatment. If they are recurrent or incomplete, then radiotherapy. Pineal region tumors, depending upon the type of the tumors, so the treatment differs if they are depending upon whether they are gliomas or pineoblastomas or what they are. So that's an overview of the treatment. So obviously, you can see that there is so much treatment on a delicate organ like brain with surgery, radiotherapy, chemotherapy, and all that. And the children have to still develop, go to school, learn, and all that. So it comes with a cost, unfortunately. So most of the now newer trials are trying to improve the outcome, but also decrease the toxicity. So there are lots of late effects that you look for. Neurocognitive deficits are the main ones, which is mainly from medulloblastoma and radiotherapy. Learning difficulties, memory problems, and behavioral problems. They are the major concern once they finish treatment in terms of schooling and becoming independent adults later in the life and earning their livelihoods, having partners and leading a social life. It's very difficult. Which is dedicating to help children surviving brain tumors to achieve their maximum. And our team in the Shahalian works closely with them. Then there is endocrine dysfunction because endocrine is thyroid deficiency, growth hormone deficiency, cortisol deficiency, puberty, fertility issues all come up. So they need to be screened for that. And then there is issue of second malignancy developing 10 to 20 years after the initial treatment, like meningiomas and AMLs, lymphomas and other things developing from them. And then of course all these things will affect the quality of life. So that must be taken into decision in terms of deciding what treatment to offer based on the expected survival and how much toxicity you need to give them. The future is getting better, looking good and getting better and better every year. So with new biological molecular technologies, identifying molecular markers in the tumors, classifying the brain tumors even better. WHO classification for brain tumors 2021 is due to come any time now. It's incorporating molecular techniques to the diagnosis. And so we will probably be able to use newer radiation techniques like proton beams and also targeted therapies, and doing quite a bit of collaborations with other groups like Pediatric Brain Tumor Consortium of Canada, SIOP Group in Europe, COG in America, CCLG in UK, St. Jude's Group in America, and other groups as well. So by doing actually more collaboration and being more aware and hard work and commitment of people, I'm sure, survival already 75 to 76% now, so it can improve. But then the quality of life should also improve. I've got more presentation to do, but I think maybe I should stop here, Boo, if that's okay, because it gives 10 minutes for questions.
Yeah, I think that would be fine, Dr. Sastry. Thanks very much.
Okay, I'll stop sharing the screen.
Sure.
Okay, so I can see you guys now. I think some of you can see, I think. Anyway, so I'll open the floor. Thanks for patient listening. It's a lot of slides, but combining all tumors, all brain tumors in one is quite difficult otherwise.
No, definitely. I think it was a really good talk on an overview for brain tumors. I think it's helpful to get an understanding of it in general, and then obviously you can do future talks maybe on more on one specific brain tumor, because there's so much more information on each one.
Yes, absolutely. So I think maybe time comes we can probably just do the medulloblastoma and then maybe astrocytoma. They are the most common ones anyway.
Yeah, definitely.
Those are the ones you will probably see on the wards more than craniopharyngioma and ependymoma and all that.
Yeah.
Yeah.
So I just had a couple of questions. One was just regarding, do you mainly get referrals for brain tumors through the neurosurgeons, or do they come from GPs and things like that? Because it sounds like your first step in management is almost always surgical.
Yes.
And I know when I've worked here, I've had phone calls about patients having something abnormal on the scan and they phone here.
Yes.
So is a normal practice, and the first thing you do really to be speaking to your neurosurgical colleagues first?
Yeah, so good question. So mainly three common routes that we actually see. One is neurosurgeons. They often land up in A&E with raised ICT acutely, right? Or they get referred to GPs for non-specific symptoms, and a general pediatrician may be involved in the beginning, gets a CT scan, referred to neurosurgeons, right? That is one route. And then we hear from them, from the neurosurgeons. Second route is neurology. So neurologists often see children with headaches, seizures, and developmental delays and that kind of things, and they do scans for them, and then they detect something and they get to us. Third route is ophthalmology. So as you can see, the visual pathway gliomas, optic gliomas, and all that, they come through the ophthalmology or the opticians. Fourth one is endocrine for us. So growth hormone deficiency, short stature, premature menarche, or premature thelarche or something. They are the common ones. I'm yet to receive a direct phone call from GP or referral from GP for a brain tumor. You can see that's how it is rare. GPs in general, one GP surgery may see in their lifetime one or maybe maximum two children with brain tumors in their lifetime. That's how rare it is for them. So they may get our letters after they have been diagnosed, but they won't see them in the beginning. They might have missed them, or they might have gone to another route like ophthalmology or community pediatrics or somewhere else.
Okay, That's very helpful.
So second part of your question was who gets involved first? I mean, we are always happy to take referral for any suspected brain tumors, no problems at all. We also have a dedicated Monday neuro-oncology MDT, as you know. So if there is any concern from anybody, they can make a referral to that neuro-oncology MDT as well. That is more so when they have already had the scans done, right? If they have not had the scans done, you can use your best judgment to see, because you don't want to refer them to an oncology and increase the anxiety of parents about tumors unless it's really there.
Yeah.
You can use general pediatric colleagues for that, or a neurology first, and then they can make assessment as to see whether this child needs a scan, and if as soon as the scan is done, then they can refer the child appropriately, because we don't want to make every parent with a headache anxious.
Yeah,
So
absolutely.
that's where the Head Smart campaign and posters will be good to kind of get guidelines as to whom to refer.
Okay, no, that's great. Thank you. I've got a question from Daniel Houghton from NHS Forth Valley. So he's asking, with collaboration, research, and trials being so important, how do you manage parents and families that understandably want to try everything and will crowdfund experimental or other alternative treatments?
Yes, that's a very good question. And actually, we face it all the time. Like, because as you know, internet and social medias and stuff like that, like parent groups and things are very, very active. Each tumor group has got some parental support groups and all that. So if you take as a whole, there is loads of investigations, clinical trials going on, phase 1, phase 2, and even earlier than phase 2, preclinical studies and all that. Parents get to know lot of it of this. So what we tend to do is most of the time we tend to offer them a definitive curative treatment if it is available, right? And these treatments are usually international. Most of them are international, like European or even truly international, as in US, Canada, and everybody, up-to-date treatment. And most of the parent groups and social medias also recommend that treatment as the first-line treatment. So that's easier. So if the patient responds to that, that's fine, and they go into remission, that's fine. If they don't, if they progress, then we also look for second-line treatments, which again could be national or international. And we put it to them that these are the things available, and this is what the recommendation internationally or nationally is. And then most of the parents actually are okay with that as well. When the problem comes when there is no second line or third line accepted treatment available, and then the prognosis is poorer, or the child is likely to be palliative or only supportive care, that's when all these other treatments come. And so which we now tend to send the tumor tissue to London as part of SMPEDS. We call it as Stratified Medicine Pediatric. It's a clinical trial where the tumor tissue is sent and the molecular analysis is done to recognize, is there a targetable gene or a mutation identified in this tumor. And then when that is done, then there is a MDT, like a molecular MDT, which has got basic scientists, clinicians, oncologists, radiotherapy doctors, everybody. It's done as an international MDT, mostly in London. And then they come up with recommendations saying that this is the mutation found. This is what the experience so far with this drug. It's either available as a trial within the UK somewhere, or it may be available as a compassionate ground drug. So then we tend to talk to the parents, say this is the situation. If it's available in the UK and it is reasonable to do, and the child has got enough time to try that, then we facilitate that, because then parents feel that it's actually something is being done. And because the brain tumors are not in number wise, they're not too many, NHS, GGNC and Lothian and other places like Forth Valley, they're able to support them because the numbers wise they're very minimum compared to the adults. So I'm yet to have anybody refuse a treatment for the child. When the problem happens when there is international availability only, not national, that's when NHS got its limitation in terms of referring, because if it is completely experimental with no proven track record, you don't want to divert a NHS fund to that. That's when the parents look for fundraising themselves and ask for our support to say, is this reasonable? Can my child participate? And we tend to link in with the center abroad and find out more information as to what is expected of them of the trial. And we talk to the parents. We sometimes facilitate a video call between the international center and ourselves as mediators, sit down and make them understand. It's the parents' decision after that to see whether they want to try that or not. But they will have all the information, and many of them usually don't go after that because they think that that's not something they want to do. But some of them still want to go and try it. And that's, and by that way, I think, they have tried everything that they can do in what is in their power, and then can, when the child dies, at least they know that they can be, taken solace from that they have tried everything that they can do. So we are there to kind of facilitate and make them understand what is involved, but they will make their decision on that.
Thank you, Dr. Sastry. And another question for me, if that's all right. So just at the start of treatment of a brain tumor, if a biopsy is taken and you've got it in storage and you can check for any targetable mutations. If you didn't find anything and the patient's gone through treatment and then maybe they've progressed or they were cured and then have a relapse type thing, would you go in and biopsy again? Can the genetics or the kind of molecular makeup change through time so that you might find a targetable mutation if you rebiopsy again?
Yeah, so that's a good question again. So at the time of relapse, if if it's possible to do a biopsy without putting the child through too much of morbidity or mortality risk, then it is good to do that, because then you can send that tissue and the original tissue both to see whether there is any clonal evaluation has happened, like there is a change in the targets. It's possible that especially with medulloblastoma example, like the responding portion has responded and the ones that are more difficult have come up back again. But that doesn't mean that it always results in targetable treatment. That's the thing. So, but as you rightly said, SMP, it's Certified Medicine Pediatric, is specifically for that, for the relapsed tumors. So, and a criteria is that they have to have a biopsy to be eligible for that trial. So yes, of course, it's definitely useful to do that.
That's great. Thank you so much, Dr. Sastry. I don't think there are any other questions. But yeah, I appreciate your time, and I think the talk was really excellent. So I hope we can invite you back again later on to do some more detailed talks as well.
Okay, thanks, Bubu, for giving me an opportunity here, and thanks to everybody who participated. So let me know, when everybody's turn goes and you want more anything specific.
Okay.
Okay, thanks very
All right.
much.
Take care.
Thank
Bye.
you.
Bye.
Bye-bye.